Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. So today I'm going to be interviewing Felix Hay. Now, Felix is an advanced nurse practitioner. He's from the UK. He will be one of the primary providers at the Healand Clinic, which is a clinic that specializes not just in men's health, but women's health as well in the UK. And I think you're going to find him very interesting. You're going to find him to be a wealth of knowledge. And so rather than give you guys another didactic lecture, what I'm going to start doing with this channel is start introducing you to some people that I have run into throughout the course of my career and who have reached out to me, who resonate with some of the same messages that I try to give to men in terms of health optimization. He's extremely knowledgeable. I'm going to have a link to his clinic in the show notes, so please check it out. If you live in the UK, as we're going to discuss in this video, it can be very difficult to have access to good health optimization care. So by all means, I highly recommend the Healing Clinic. Check it out. And I hope you guys enjoy this conversation. We're going to be having a lot more of these as time goes on. So enjoy. So today I have a very special guest, Felix Hay, all the way from the UK. Felix is a nurse practitioner in the UK and is running a men's health and hormone replacement clinic in the UK. And we're going to have a conversation with you guys about testosterone therapy, some of the pros and cons, and maybe answer some of the common questions that you and I both get on a regular basis from patients. So, Felix, maybe could you tell us a little bit about your background and the clinic that you are going to be opening up any day now, I believe?
Yeah, hi. Thanks so much for having me on your channel, Andrew. I really appreciate it. Yeah, as you say, I'm an advanced nurse practitioner by background. Bulk of my experience is, much like yourself, is in emergency medicine in the UK, working for the NHS. And a few years back, I got into hormone replacement work right just before COVID, actually. And I sort of stumbled into that through a definition of testosterone deficiency for myself. Being someone that works in medicine and has worked in medical research as well, I got a bit sort of deep dive into what that involved, and quickly realised that there was a bit of a gap in knowledge between myself and the people that were trying to help me, in inverted commas. Yeah, so I kind of got into that area of work like that. And
I worked very diplomatic.
Yeah. So you know, I never like to put anybody down for a gap in their knowledge, because it's just something they haven't learnt yet. And hopefully, with things like you and I are doing, we can maybe help them close that gap a bit.
Absolutely, and that's the whole point of this channel and our conversation here, is just to help men get access to good and most importantly, evidence-based information on this subject. Because there is, I had a very similar experience when I started on testosterone, that there is a tremendous variation in the medical community about, in terms of truly understanding the benefits, the risks, and alternatives to testosterone therapy. And it's, you know, I've had physician colleagues tell me that I'm going to get prostate cancer, which would
man.
I've had them say I'm going to drop dead from a myocardial infarction.
Yeah.
And then, you know, I had a small handful who obviously knew that that was not true and were very much in support of it. So there's a lot of mixed messages, even today.
Yeah. For sure, and I think you know, that's something that the clinic that I'm opening with my good friend and colleague Dr. Babar, who's the medical director, it's called Healand Clinic. You can find us online at Healand Clinic across all the social media platforms. We've just gone live with our YouTube channel 2 days ago, so I'll pop a link in the description for that. But yeah, that's what we're trying to do at Healand, is try to raise awareness of the fact that this is an underserviced area for men, and it's under-recognised, misdiagnosed as depression a lot of the time. And the thing that we're trying to sort of get at Healand is a more holistic approach to managing this, because it isn't just about, as you know, Andrew, it's not just about giving a bit of test and then seeing what happens. There's a lot more to it, which I hope we'll go into now. But
I agree completely.
Yeah.
Now, maybe you could speak on the fact that you know, maybe tell the listeners. Most of my listeners are in the United States. You know, things are pretty bad here in terms of, you know, the general medical community treating men with low testosterone and just having an understanding of how important it is. But I've also heard some stories about how things are in the UK.
Oh.
Could you kind of fill us in a little bit?
Yeah. So it's interesting that you bring this up, because in the UK healthcare system, we kind of had this skewed idea that in America it was great for TRT. And my conversations with you recently have changed my mind on that. So we're in a bit of a similar situation. So as I've already alluded to, it's often misdiagnosed as depression, and then you end up going on a completely different treatment pathway that perhaps isn't necessary, had someone had the forethought to think maybe we should check their hormone profile as well. Now, even when it is diagnosed, it's exceptionally hard to get that on the UK free healthcare system, the NHS. In fact, the British Society for Sexual Medicine guidelines are extremely stringent. So you have to have qualitative symptoms that we'll probably go into in a bit more detail in a bit, but then a testosterone level total of less than 12 alongside those qualitative symptoms, and then that only gets you consideration for perhaps, and I don't like this wording, a trial of TRT, which they recommend as Testogel, so an unbound form of testosterone that's renowned for raising hematocrit and not particularly good at keeping stable levels, and that's at the discretion of the person who's treating you. Now, the other side of that is if you were to have perhaps a normal total testosterone that's low or borderline, so towards 12, but have a free testosterone that's less than 0.220, although the BSSM just recently updated that to be less than 0.18, which is exceptional. That's nanomoles per litre. So I know you guys work in nanograms per deciliter.
Right, I think we have to do a little bit.
Yeah. So to give that some
exceptionally low numbers.
Yeah. So to give that some relativity, our 12 nanomoles per litre would be equivalent to 346 nanograms per deciliter for you guys. And I know the American Urology Association, I think I'm right in saying that you have to be less than 300, don't you?
You're right. So actually, they're even more strict over here.
Yeah.
There's two primary sets of guidelines that most U.S. physicians use, and I'm not a huge fan of either one of them. They have their utility, but one is most physicians will use the Endocrine Society guidelines,
right?
And then there's the American Urological Association. They're very similar, but the Endocrine Society, they updated their guidelines. I believe it was in 2018. And so they mention a cutoff of 300 nanograms per deciliter. There's no mention of free testosterone whatsoever.
Wow.
But they also have a clause in there, or below the lower limit of normal for the assay.
Right.
And that's where it becomes a bit problematic because, and maybe you can speak to this if this is an issue in the UK, but the reference range, what is considered to be normal here in North America, has been shifted to the left.
Yeah.
As of, I believe it was about 2017. And it's so most of the assays that I get here will give a lower cutoff of roughly like 249 nanograms per deciliter, which is
incredible.
Shockingly low.
Yeah.
Shockingly low.
Yeah.
And so, and there are reasons for that, and maybe I can touch on that just briefly without,
of course, yeah.
Going into a long rant about it. But the prior values, the prior normative values here in the United States and North America were probably more similar to what you guys use. Depending on the lab, it was roughly maybe 300 to 1200, maybe 350 to 1200 nanograms per deciliter, which is a bit more reasonable. But those values were based off of young, healthy men, like age 18 to 40, who were not obese or overweight,
right?
And who were otherwise, these were considered lean, healthy, average.
Yeah.
Men. Well, in 2017, they did some new population studies, and in order to make the sample more representative, more inclusive of the standard American male, they included men who were considered overweight by BMI, so not clinically obese with a BMI of 30, but they included men who were overweight, and so they introduced this unhealthy population into the sample.
Yeah.
And of course, as I'm sure we'll discuss, I mean, one of the best way to ensure you have low testosterone as you get older is to become
overweight. Yeah.
Especially visceral body fat.
Yes. Yeah.
And then the other issue with that, of course, is that BMI is an imperfect measurement. Obviously, it's much more useful to use a body fat percentage.
Of course. Yeah.
So there are many men who are in that sort of, we call them the skinny fat group, who perhaps by BMI, they may have a BMI of less than 30, but really their body fat percentage is above 25%, which is what we
exactly
use in North America as a cutoff to define obesity. So really what happened is I suspect they introduced a lot of men who were actually clinically obese into this sample population, obese by body fat percentage.
Yeah.
And then, not surprisingly, that skewed values. It shifted that bell curve significantly to the left.
Yeah.
So it's, which I think is really wrong. I mean, you don't want to define normal based off an unhealthy. You want to find the healthiest representatives in the population.
And it needs to be generalizable, doesn't it? Like, so what you've described is exactly what's happening in the UK, but unfortunately, we've gone even further. So we now have reference ranges dependent on demographic and geographic area. So so you can have localized reference ranges. So I got an email a while back saying that this gentleman insisted on referral to the clinic, but his total testosterone was deemed normal because the reference range was between 1.9 nanomoles per liter and then the upper end of normal, which is 29 nanomoles per liter considered in the UK. Now 1.9 nanomoles per liter, bear in mind that 12 is a cutoff for borderline consideration and 8 nanomoles is guaranteed you must start TRT. So 1.9, to say that's normal is absolutely unbelievable. Now that prompted me to look at this area where this gentleman had come from and look at the statistics. And the latest data I could find at the time was from 2018, and there was an obesity crisis there where around 79% of that population were considered obese, and that included children. so it's it skewed the statistics a little bit, including children, but it was still a huge number. 80% obesity rate in that specific geographic area is just, and I think that leads nicely onto what you were alluding to just now. The biggest thing that will guarantee you to become hypogonadal is going to be visceral fat and adipose fat causing substrate for aromatase conversion, isn't it? It's
absolutely. It's as we both know, I mean, visceral adiposity wreaks havoc on your body, and the endocrine system is just the tip of the iceberg. Of course, there's all these other issues with it as well. But it sounds like the United States and the United Kingdom we're tracking.
Very much. Which is why I guess there's room for services like ours, and I feel like sometimes we talked about this the other day, didn't we, when we had a chat? You feel like a lone crusader sometimes, don't you? It's trying to save some of these guys. It's
absolutely, and it's tragic because I jokingly say I have a very bipolar medical practice because I spend a lot of time in the emergency department, taking care of a lot of times it's either substance abuse issues, but also really it's complications of long-term obesity. And metabolic syndrome and diabetes and cardiovascular disease, and I see the fallout from that. And then I get in my men's health practice, and I have some men like that as well, but I have a large percentage of men who are really dedicated to being
healthy.
So I see very little in the middle. I see the bell curve.
This is it.
But it's really tragic. I mean, and it's hard, so you and I see this every day, in the emergency room, in emergency medicine, but it's very difficult to understand for the average layperson who maybe has not had any major medical health issues yet, just how bad things can get for a man starting in their 40s even. I routinely see heart attacks in men in their 40s.
Or how many ruptured AAAs have you seen in younger men? Exactly. Like, I think if you were to just show, if there was to be a sort of scare tactic advertising campaign for men's health, and show someone in the ER, real life patient that's had a ruptured AAA, and that means abdominal aortic aneurysm for people watching, and what that can do to you, then it would, and at the age that it can happen, it might make people take things a little bit more seriously with regards to their own health.
Without being too specific, I worked the day before yesterday, and I took care of a 36-year-old young man who was 160 kilos, and came in with chest pain and EKG changes, and he had a systolic blood pressure of 260.
Oh, it's just,
diastolic of 135.
I mean, it's just, it's there have to have been red flag warning signs for that young man before this.
Yeah.
Like, so how does it? It's heartbreaking, isn't it? Like, and
It truly is. And the sad thing is, I think in the UK and in the United States, I mean, we're at least 3 generations into this obesity epidemic. And so now, it used to be that you would get overweight and obese, in your older years.
Yeah.
And then now, maybe the next generation in their 30s and 40s. But now these kids are born, they're obese in the womb.
Yeah. You're getting big babies. Yeah.
Yeah. I mean, I've delivered 13-pound babies.
Oof.
Recently.
It's just...
and so I routinely see 8 and 9-year-old children with fatty liver disease.
Oh yeah. Non-alcoholic fatty liver disease. Yeah, we see that. And type 2 diabetes in kids as well. That's rising in the UK. Probably is in the States.
It really is. It's going to. I know we're here to talk about testosterone. This epidemic is going to. It's breaking the back of our medical system.
Exactly. Yeah.
Certainly, it's going to do the same for you. And really, all Western countries, I think, that,
for sure,
whether they have a socialized public system like you guys do in the UK and in Australia, or a kind of a hybrid system, I guess. It just no system can survive
that pressure.
Population with 80%
diabetes. Yeah, exactly. And I think sort of bringing it back to the more sort of testosterone side of things, the obesity pandemic, it's not just an epidemic anymore, is what is skewing these reference ranges that I think we were talking about recently, informs the academic side of research that doesn't translate well to clinical practice, does it? So you've got that sort of extreme of these professors of endocrinology going, the reference range is this, these are the indications for treatment, nothing else, and these are the treatments you can give, nothing else works. And I suppose it's worth talking about that a little bit, and about how the evidence base from academia doesn't actually translate very well in clinical practice in real life.
It sure doesn't. And I know you and I have been doing this long enough that we have seen men who would fall outside of the typical guidelines, whether it's the British Society of Sexual Medicine or Endocrine Society, who have fallen outside of those guidelines, yet have had incredible health transformations with therapeutic testosterone, in addition to lifestyle modifications.
And I think that's key as well, isn't it? It's about sort of the clinical context of taking what the evidence says. And I think I'm a big fan of something that a colleague of mine in the UK said once. His name's Dr. Hamid Kamali, very well-informed guy. And he coined the term, instead of evidence-based medicine, he coined the term evidence-informed medicine. Now, the reason I like that is because it means that you as a clinician can take your clinical contextual experience and use the evidence to inform your decision-making. It's not so black and white as this is the guideline, you must do this. And I think that's a style of medicine that's not being practiced very often. And I think, in part, not to again digress off into a rabbit hole, that certainly in the UK, the medical education system is feeding, because we're over-protocolizing everything and saying, this is the guideline for this, you find X, you do Y. There's no room anymore for clinical decision-making based on what the research says and how you can interpret that and contextualize it for that patient in front of you. And I think that's something that needs to not be a dying art, and it's something that I know you're pioneering as well.
Yeah, you have to apply all of these studies. None of them were done on the patient that's sitting in front of you.
Yeah, exactly. Yeah,
that's the thing. And so they may not apply at all to the person who's in front of you, and that's that art of medicine. And we have the same issue here with protocolization, and I feel like they're trying to replace us with AI.
Yes, ChatGPT is going to be in there, isn't it? Yeah.
And they won't need us anymore.
Yeah.
But a lot of it too is it's driven by cost consideration.
Yeah.
Because if you can deny somebody treatment based on an arbitrary cutoff, well, that's one less patient.
That's workload management, isn't it?
It's unfortunate, but then the reality is, if you just spent a little bit of money up front and taken care of this early, then you would actually save money down the road.
Yeah, preventative medicine. No one's interested in that anymore. It's
You could have your $100,000 coronary bypass surgery. 10 or 20 years, or you could spend a few $100s a month
Yeah.
or
And never need that. Yeah, and I suppose like on the flip side of that, you've got your academia. Then in the middle, you've got us, the guys trying to use the evidence in an informed manner, and then you've got the other side, haven't you? You've got the bro science. So
that's a whole
yeah,
other,
I mean, because it just sort of made me think of that when you talked about interpreting evidence and like whether the study is applicable to the patient in front of you, and it made me think of rodent model studies and how often I see those getting thrown around the internet saying, well, I mean, I saw in this study that the estradiol being this is fine, and then you look at it and it was on Hind-Wistor rats.
Yeah. If you're a veterinarian, great.
Yeah, exactly. Or sometimes even worse, it's in vitro. It's not even in vivo studies.
Right.
Yeah.
Well, a lot of people read abstracts and they don't read the actual study, and then you try to read the fine print, I should say.
Yeah. And
one of the things that just to touch a little bit more on the protocolization of things, and you and I think look at this in exactly the same way. I do look at the guidelines. I do think that they have some value.
Yeah.
The Endocrine Society guidelines, in my opinion, they're not written for endocrinologists, and they're not written for other experts in testosterone therapy. They're written for a GP who has no formal training, and it just sort of gives them a safe path.
Yes. Yeah.
You won't get in any trouble if you just stay along this path. Now you will miss a lot of opportunities to help other people.
Yeah.
But you'll stay on the safe and narrow path. But unfortunately, it becomes like this stuff is like holy writ, and you can't. You deviate from these guidelines. But it's sort of like advanced trauma life support, or maybe I don't know if you have that.
We do, ATLS, APLS,
ACLS. ACLS and ATLS are not. They weren't designed to teach cardiologists and trauma surgeons how to take care of. They're for non-experts.
Yeah.
Right?
They're for us guys at the front line when we get someone in with a cardiac tamponade and we've got to crack their chest and do a clamshell. I
don't need to take ACLS. Thank you very much. I do ACLS every single day.
Exactly. Yeah.
And same with ATLS. So it's important to remember that. But my approach, and I think yours as well, with in terms of testosterone, is I don't just look and see, okay, you've got a number of X, and then you either do qualify or you don't qualify for therapy. I think that's a very black and white approach, and I think you're going to miss the opportunity to help a lot of men if you take that approach.
Yeah.
So what I do when I see a man is I think more of like, does this man have one or more underlying medical conditions and or a symptom complex that stands to benefit from a higher level of testosterone than what he has?
Yeah.
Whether it's 12 or it's 3
and
or 400.
and those symptoms are both qualitative and quantitative, aren't they?
Exactly, they are. I really feel like the diagnosis of hypogonadism, or if we want to call it, I like partial androgen deficiency a little bit better.
It's descriptive.
Is a clinical diagnosis, and it's a clinical diagnosis that you then support with laboratory data. Really, it's a clinical diagnosis, and maybe we'll talk about symptoms a little bit because they are a bit non-specific. But my approach is if I've got a man with a lowish testosterone, and we can argue about whatever that might be, but he has a set of symptoms or he has an underlying medical condition, and I have done an appropriate medical workup. This is important. We'll touch on this too. That I have ruled out other
causality,
serious medical issues, or there's a lot of lifestyle issues that need to be. And sometimes when you scratch the surface, you realize that that's the cause. I've done an appropriate workup and I haven't found anything else. Then I think it's appropriate.
For sure.
It's appropriate to have that conversation, and that may be a trial of therapy. And because I never promise men that I'm going to fix, I'm going to change their life. Sometimes I kind of know that I will, but I never say.
You can't.
Right? I personally will discuss maybe a 12 to 16 week trial of testosterone therapy, and if we have made major strides in your health and you want to continue on it, then that's great. If we haven't moved that needle very much for you, or you have side effects, or there's some other reason, it's okay at that point to discontinue it.
How would you, if you do discontinue, if they make that decision, do you have a particular restart protocol to help their pituitary gland kick back into gear?
It depends. I discuss that with with them. A lot of it depends on how low they were in the first place.
Yeah.
But yeah, I mean, obviously there's two approaches. You know, after 12 weeks, obviously you do have some suppression.
Yeah,
but
it's not
it
massive
comes
though.
back fairly quickly. And, you know, in general, I'm sure you've seen the same thing. If the longer you're on testosterone therapy and the older you are, the longer it may take for your pituitary axis to
for sure. Yeah.
But if it's say a guy, you know, early 40s, I've had him on for 12 weeks. You know, generally within 3 or 4 months, those LH and FSH levels will return, and you know, we can just see how we feel.
Yeah.
If we want to speed that up a little bit, or for whatever reason, I mean, you know, N-clomiphene or clomiphene, you know, is an option. To sort of kickstart things a little bit for them, and especially if they're very symptomatic. Because those first couple months,
it sucks.
Might be a little rough for them. Although I've been surprised, some men do really well when they come off.
Yeah.
But a lot of men, just obviously for obvious reasons, don't feel good. And so it's not unreasonable. It's very safe to consider a short. I prefer N-clomiphene. If it's available. It's not always available. So you can use Clomid or clomiphene to.
No, I'm with you on that. N-clomiphene citrate definitely better than clomiphene.
Is that available in the?
It is, So we aren't subject to the biologics law that you guys are in the States. So we still have very ready access to compounding pharmacies here. So
wonderful. I can get it through compounding pharmacies. It's touch and go. It's not technically FDA approved. Which is sort of silly to me, because every time obviously when you give clomiphene, you are also giving N-clomiphene.
Yeah, exactly.
It's like, well, why does there need to be this separate approval? But that's a whole other conversation.
It's
if I had, I agree with you. N-clomiphene far superior.
No,
I do use that in young men quite a lot.
It's definitely effective. You see their FSH and LH skyrocket when it's been sluggish to begin with. But yeah, like so. In terms of that, I think that leads us nicely on to sort of the next bit. Like so, TRT effects. Like we've already said, it works for some and does great things, and not for others. I think that's a real key part of our conversation when we get these new guys, isn't it? Like managing what the expectations and outcomes might be. So you know,
the bro forums, you know, tell these guys.
They're always referencing supraphysiological dosages, though. I believe. You're gonna feel like God.
And you know, I think it's normal too that, you know, you're going to have a bit of selection bias online. You know, the people that have a wonderful and great experience are going to be more vocal.
Of course.
The ones that don't.
They're not going to be online telling you how terrible they're feeling.
Exactly. They're too terrible.
They're not at the computer because they're in bed.
Exactly. So there's a bit of selection bias there. But, it's absolutely true. And I, if anything, I try to undersell it a little bit.
I think that's a good strategy.
Because you know, I don't want men to be disappointed, and you know, most of the time, if you select the right patient, if you've done a good, thorough workup and you've asked all the right questions, you know, as an experienced clinician, as you know, you're going to have an idea. I really think this guy will benefit.
Is it in their best interests? That's the question in your head, isn't it? Is this in their best interests?
It's just like with any intervention or any medication, you can't always predict.
No, exactly. I mean, you know, that's a rabbit hole in itself, isn't it? Like sometimes the same dose for similar patients will have massively different levels, and I think you've actually done a brilliant video on that. You should probably we'll link it in the top of this one where you looked at phosphodiesterase type 7B gene polymorphisms. That was an awesome video, by the way.
Oh, thank you.
And that
something that you've seen it. You know, you give 2 guys the exact same dose of testosterone intramuscularly. You know that they got it. And you see differences of like 300.
It's similar background, similar body habitus, but just hugely different levels. It's crazy, isn't it?
Well, and that's why I love, you know, that you're with your clinic. I mean, and you clearly understand this. This sort of medicine needs to be very personalized.
Yes.
And it's why we're both against these protocols. You know, unthinking blind protocols, because there's as genetic medicine advances, I mean, if there's anything we're learning, is just how different we all are. We're all fundamentally the same, but boy, we've got some serious.
Exactly, yeah. Underneath the surface, we all have our own inner workings, don't we? And that has a massive effect on pharmacology, especially when you're looking at testosterone. But it's all of this is to me, like when we get the right protocol, we get the levels in the right range. It's all a moot point if they're not doing the right things with their lifestyle to maximize that benefit. And I think that's something that's always worth talking about. And I talk about it a lot, and I'm sure you do as well. There's no point in commencing TRT if you're overweight and your attitude is that you're just coming for the jabs and you're not going to do anything else, like, because you are not going to benefit from it, like you just aren't, like. So
100%. We've all seen guys like that who just won't put the work in.
No, yeah.
And their results are very lackluster.
Yeah, exactly. Like, and we at Healand Clinic, we're looking at this from a more holistic side of things. So if you look at our website at healand.co.uk, you'll see we've got psychotherapy services. Very soon we're going to go live with our partnership with a very quite a famous fitness brand in the UK, because they're going to allow access to workout routines. We've got body composition scanning that then suggests supplementation and diet regimes for the patient, and then they can come back and utilize that and set goals and see how far they're working towards it. It attaches to an app on their phone so that it encourages them to keep going and things. So so we're really, and the other thing that I think that we're not, that a lot of other clinics in the UK don't do, and there aren't actually that many, is going back to what you were saying about individualized treatment. What I don't want Healand Clinic to be is you come in and you get this protocol of treatment and the next patient gets the same. Like, it's, they may not respond to cypionate. Yeah, they may not respond to cypionate. They might respond to undecanoate. Like, they might just take a bit longer, and they might be better on a weekly dose of what we call libido in the UK, or testosterone undecanate. And I want to give our patients access to the different preparations and esters so that we can find the right fit for them. And I'm sure you probably have a similar approach in the States in getting the right treatment for the right patient, and it's key.
I think you have access to more esters than we do.
Yeah. We're quite lucky. That you've got to get a lot of agreements from a lot of different suppliers, but which takes time. But yeah, the choice is there. It's just then you've got supply issues, which can be an issue. But eventually we hope to evolve into to sort of stocking the various esters, or the more popular ones at least, on site, so that patients can go home with it and they're all sorted. But that will be an evolution of the practice as we open and get more patients through the doors. But we're hoping to soft open next week, and our big launch event is the 28th of July, 2023. So
very exciting.
I think it's been absolutely brilliant talking to you, Andrew, and I really thank you for having me on. And I think to summarise what we've discussed, TRT isn't a miracle cure, is it? It's going to normalise your testosterone levels to allow you to have the energy, the frame of mind to put in the work to make your health better at the end of the day through doing a more exercise than you are, or just at least being more active than you are already, managing your diet choices and controlling your weight. And I saw a great quote actually that I think fits in quite well here on Instagram the other day, and it just said, "A body that moves more wants to move more." And I thought that was brilliant, because I have that in my head when I wake up at 5 a.m. to go on the spin bike to do my fasted cardio, and that everybody has that moment where they're like, I don't want to do it, but then when you start moving, you're in the gym and you're moving more. It's perfect, and I think it summarizes how you can maximize the benefit of being on therapy, on testosterone replacement therapy, brilliantly.
Absolutely, and it's it's so gratifying to see. It's very different than the emergency department, as I'm sure. When a man really, when he takes that to heart and he gets very serious, and he gets when the nutrition is dialed in as it should be, when he finally gets when the exercise is dialed in, and when he's finally stable in terms of hormones and things are at a healthy level, when there is such an amazing synergy between the three of those things, and you start seeing changes that you would never see with each one of those things done individually. I think of them as like three big gears that just turn each other, and the more one turns,
this is it.
Turn the others. Because many men they want to exercise. They know that they should. They can't get off the couch at the end of a a 10-hour workday, they're exhausted.
Yeah, falling asleep. Yeah.
I knew a guy that had a patient that he would fall asleep in his car. He would get to the gym, but then he would fall asleep in his car.
In the car park.
He couldn't get into the gym.
Man.
The parking lot.
Yeah.
And he, once his testosterone was corrected, he finally had the oomph and the drive to now start really focusing on the training part of things and getting organized in terms of his nutrition. And that guy lost close to 60 kilos in the first year.
I mean, that's amazing. That's an incredible story, isn't it? Yeah.
And I would challenge any other medical specialty or any endocrinologist, urologist, andrologist to show me those kind of success stories.
Exactly. Yeah.
And they can't do it.
And that's like you said, that's the contrast between emergency medicine practice and what we're doing here. But at the same time, I think it's okay to like both. Like I still like I'm a glutton for punishment. But to have that longitudinal relationship as well, I think is fantastic, and to see the success. Yeah, brilliant.
Without question. Yeah. Well, we should probably talk about. One of the things in the United States here, we have more access to TRT.
Yeah.
The quality of clinics is not
what
it should be.
Yeah.
We're starting to get more clinics like yours, but most of these the guys that come to me mostly are coming from what I call these windmill clinics, where in my opinion the proper medical workups
have been skipped.
So maybe would you mind touching on that a little bit?
Sure.
How you approach, let's say I'm 49 years old. Let's say I came in to see you. When I started on testosterone therapy, my levels were, I had 2 levels just under 300 nanograms per deciliter. And let's just say I was pan positive on all my symptoms.
Yeah.
So having said that, maybe you can talk a little bit about how you approach something like that.
Yeah, definitely. Yeah. So
I think you and I do the same thing.
Yeah. If you were to come to me with that medical history, obviously I'd probe a little deeper to look at other medical background. So your past medical history, thorough history and physical exam, and I'd be looking. You've got the quantitative numbers. That box has been ticked, but
Absolutely.
I would want to make sure that those numbers included comprehensive diagnostic tests of other parameters. So that's something that I think is really key. So thyroid function, I'd definitely be wanting in there. I'd want a full lipid panel. I'd want, you call it a CBC, but we call it an FBC, so full blood count or complete blood count. And I'd want to look at renal function as well. Whilst that doesn't have a massive impact, it gives me a better idea of how your body's organ systems are working together. And then of course I'd want to be looking at those gonadotropins, because that's going to be the key to defining what type of hypogonadism you have. So because you've got, as we know, we've got essentially four different kinds. You've got primary, secondary, tertiary, and functional. So you can only define what type of hypogonadism someone has by measuring their gonadotropin levels, because that will give you the indication as to where this is originating from. So with your primary hypogonadism, that's a purely testicular driven origin. So this could be things as simple as testicular injury. So you could have been a professional fighter and just taken too many hits to the groin over your time. You could have had CA testes, so cancer of the testes, and had orchidectomies. You could have had any kind of surgery. So cryptorchidism is one that's mentioned in the British Society for Sexual Medicine and the European Society for Endocrinology as a causative factor. Then a whole host of other things. So infection is another one. So chronic orchitis is something that I've seen loads of. You ask a man, and then people just go, I just thought it was normal for them to ache all the time. It's just like, no, it's not. So and that's such an easily treatable condition as well. A couple of weeks of a broad spectrum antibiotic and it's gone. But by that time the damage can be done. So that's another cause for your primary. Secondary, now this is where your gonadotropins really come in, and what I'm looking at is with your primary picture, you'll see your FSH and LHB skyrocketing. They'll be climbing up because essentially those cells in the testicles are not receiving the message from the brain in the form of that FSH and LH. And it just, your brain's quite clever and goes, all right, we'll send more messengers to knock on the door some more. And then they just back up, and it just ramps them up, and then they just skyrocket, and that's when you see that diagnosis of primary. Now, in secondary, you're going to have that signaling issue, but probably in reverse, where you've got very little of those messengers getting to the target cells. Now, you can have lots of reasons for having that. It could be hypothalamic as well. Like, so you might not even have enough GnRH or gonadotropin releasing hormone secretion. So that from the very get-go is going to put you in a secondary picture. And then tertiary, you've got other hormones that impact how your testosterone levels can go up or down, with the main one being prolactin. So if you get a sky-high prolactin as a male, then it's going to quash your testosterone levels. Now, the biggest concern you would have as a clinician there, seeing an elevated prolactin in the thousands at least, is a prolactinoma or a microadenoma of the pituitary gland.
You've probably I've picked up many of those.
Yeah, sure you do. Yeah, exactly. Yeah, and then of course you've got functional. Now this is the one that's quite controversial, isn't it? So we as human beings, we quite like enjoying life. so we tend to do things to try and amplify that enjoyment of our life. So we might put substances in our body that amplify endorphin releasing moments. So the main one being alcohol. Then there's recreational drugs. So you've got your calcium channel blockers like cocaine that will have an effect on your HPG axis.
Glad you mentioned that.
Yeah, and you know, all the party drugs, in fact, amphetamines have an interaction as well, because we need to remember as well that they also impact on the HPTA, not just the HPG axis. So your hypothalamic pituitary thyroid axis is massively sensitive to those kinds of drugs, and that then in turn has an impact on SHBG production, which impacts your HPG axis. A big rabbit hole. We can probably do that in another video. And then you've got the last one, which people don't like to talk about, but I'm not in the least bit bothered talking about, and that's steroid abuse. Like, so obviously it's going to be an HPG axis disruptor, because you're turning off that signal from your brain saying, the negative feedback loop says, we've got this much testosterone, this much estradiol, we need to secrete this much FSH and LH to continue the process. If your body senses that there's already loads of testosterone, and then it will also sense that there's loads of estrogen because of the conversion between the two, it will just switch off the FSH and LH, and you will get pituitary suppression. And that right there is when someone says, no, I'm completely, like, never touched anything like that, and you get their panel back and it says less than 0.3 for FSH and LH. You're like, really? and with those guys, I'm not sure how you approach them. I'm not going to actively endorse them actively running cycles at that point in time. What I will say to them is say, look, these are lifestyle choices you make. It's not illegal in the UK to own and take steroids. There are certainly much worse things you could perhaps be addicted to. But I will recommend that they stop. And if they don't return to their normal baseline for their HPG axis function, I will speak to them again on the premise that they agree, and this is part of my consent process, that they won't abuse steroids again whilst under my care.
I do exactly the same thing. I'm not a police officer. I'm a physician.
No, I'm not going to call the police on them.
If you abuse methamphetamines, which many of my patients do, I'm not going to not take care of you.
No, exactly. You know what I mean?
I'm not going to prescribe you Adderall.
No, exactly. I'm not going to give you the legal stuff.
At the same time, just like I'm not going to prescribe you testosterone if you're actively using black market steroids.
Yeah.
But we'll probably do some follow-up series on.
I think so. Yeah. I think that's a good idea.
So those guys kind of fall into that category. The other thing I see, and maybe you can tell me if this is an issue in the UK, but we have much stricter laws on anabolic steroids here. They're considered what we call Schedule 3. So you're looking at serious time. Certainly if you are selling anabolic steroids, then it's a felony. But even possession is criminal.
Yeah.
So many young men are using SARMs. Selective androgen receptor modulators, and there's many of them.
Yeah.
And these are all sort of failed drugs. They're not based off of the cholesterol backbone, so they're not steroids per se, but they interact with the androgen receptor, and they have various amounts of anabolic and androgenic activity. But they come from these sort of gray market peptide labs, and research chemical sites. But those suppress the HPG axis as well, despite what the pros will tell you. You'll see young men in their 20s, and they're when you ask them if they're using anabolic steroids, and they will truthfully say no. but you have to ask
Follow
about
up. Yeah, so I do ask about SARMs. Yeah, so yeah, you're completely right, and we do have a similar issue in the UK, and we actually have a bit of a problem with your younger guys, so between 20 and 30, using them on purpose to temporarily suppress themselves, and then they will take Clomid or Nolvadex to bring their FSH up to low normal, but still have low testosterone levels, and then tell you a story about how they have all these other qualitative symptoms. Now, what they don't realise is that we as clinicians have other ways of seeing how it skews other blood parameters to know whether you're using them. So you know, I don't recommend doing that with either myself or yourself. But it's
A for effort, but
yeah, exactly. But it's you know, to people who are well versed in the art of the androgen receptor, it's easy to see. But yeah, we do have that issue. So yeah, a lot of people using the biggest one I've seen is RAD 140, LGD 4033, and they are very suppressive, like very.
Ostarine and things like that.
Yeah, Ostarine's considered the weaker one, isn't it? And like, it doesn't suppress at all, but it does. It's
one of the tip-offs I've seen is I've had a few young guys come in with single-digit HDL levels.
Yeah, there it is. Yeah.
There's something about that substance that just crashes the HDL.
Yeah, it crushes it completely.
That's a dead giveaway.
Yeah,
you know,
yeah. Yeah, exactly. This is why the importance of your lipid panels as well when you're doing these things, and it's just to work out that causality, isn't it? You don't want to start someone on what potentially could be something they're on for the rest of their life, and it's not. It's not like people have this idea that you're going to start TRT and everything will be amazing. There's a real titration period, isn't there? You've got to. There's a lot of tweaking of dosages. There's a lot of sacrifice that has to be made with your lifestyle. And you can't just take it and then go back to being gluttonous, for example, or doing no exercise. You've got to.
I wish it was that easy.
Yeah, exactly. Yeah, wouldn't it be great? But yeah, working out the causality, like that's something like a Healand Clinic is something that we're very hot on, because we're not one of those wellness clinics that you go into and they go, here's 200 milligrams a week of test sip, 750 of HCG, and 2 units of HGH every day to keep you feeling and looking young. We're not like that.
We'll just bill your credit card every month.
Yeah, exactly. Direct debit is that's a red flag for me when clinics do direct debit.
It really is it's terrible medicine.
Yeah,
It's just not. You know, our job obviously as clinicians is to do what's best in the best interest of the patient.
Yeah, exactly. Yeah, I think it's primum non nocere, isn't it?
Of course, but at the same time, it's you know, unfortunately in the U.S., these sort of clinics, they sort of put their bottom line financially ahead of the best.
Yeah, and you know, I mean, that's worth touching on because we both run private clinics. So yeah, they are a business, but I think you have to find that delicate balance between ensuring you're doing first do no harm, primum non nocere.
We have an ethical obligation. We took an oath.
Exactly.
It's that doesn't just because we run a private clinic. It doesn't. We're not exempt.
No, exactly. Yeah, and even more so, I think it's more prominent in your mind to do right by your patients having your own business because it is your livelihood. You know, what you don't want to do is take that gung-ho attitude that you see from some of these. I like what you call them, pop-up clinics, like or windmill clinics where they just churn them in and out. Like, I mean, that's a recipe for disaster, not only for the patients, which is who we're here for at the end of the day, but also for those clinicians. Like, they're risking their registration. Like, and then they and their families are ruined as well. It's like, you know, nobody wins in that situation. So I think, you know, it's about ensuring that where we're coming from is patient centered. Like, and I think that's
and unfortunately, we also have to be, you know, cognizant of the scrutiny from our consultant colleagues that maybe are not as understanding of testosterone, and so if they see us doing things that are way outside of
their own comfort zone,
or God forbid there's a bad outcome with a patient, the United States is extremely litigious.
We're
a very litigious society, and so you can expect some attorney with a magnifying glass is going to be very closely. But if you've got a panel of like you're going to have with a panel of hundreds of patients who are fabulously healthy. You can show them objective data that we have started at this place and now we are over here. And that will protect you.
Yeah, exactly. Yeah, for sure. Yeah, no, I mean, that's certainly something we're doing at Healand as well. Is part of our sort of consent process for treatment and things is about agreement to patient feedback stories being publicized and things, and obviously they can opt in or opt out, but yeah, like patient journeys I think speak volumes. Like it's like your story about the guy that lost 60 kilos. I mean, that's incredible, isn't it?
It's incredible.
Yeah,
it's incredible. Yeah, your patients will always be your best marketing.
Yeah, for sure. Yeah.
In addition to yourself, because as a clinician, you have to look the part and walk the talk, so to speak. And, you can't be an obese.
It's like when, has anybody ever trusted an overweight nutritionist or dietitian? Like it's not really.
Yeah.
No,
you trust overweight chefs. You can trust.
Yeah, exactly. Yeah, the food's good. Yeah. That's the only time that one works. Yeah. Yeah, never trust a thin chef. Yeah.
Absolutely.
But no, it's been absolutely brilliant. I think if you want to find out more about either of our clinics, I think Andrew, yours is Man Medicine, isn't it? And that's manmedicine.com.
I'll put a link.
Perfect.
I publish this video on my page. I'll put a link.
Brilliant. I'll pop one for you as well. Ours is healand.co.uk. And I will pop a little card up in the left-hand corner somewhere. Because my intro video for our YouTube channel goes live. It's me talking a little bit about my background and what the clinic has to offer. So I'll pop that up there somewhere.
All right. I'm looking forward to watching.
Yeah. I'll send you all the links. Brilliant.
Okay.
Fantastic.
Yeah. Well, we should continue these conversations.
Definitely. Yeah. I'd be really pleased to.
I don't even think we hit all the stuff on our list.
No, we didn't. We got loads. Yeah.
It's a complicated subject.
It is. Very nuanced. Yeah.
It's a bit nuanced, and I love that you are entering into this space because there's a dearth of good information.
Yeah.
There, and people need to hear. They need to hear success stories, and they need to hear this kind of more reasonable approach.
Oh yeah. It's just and that's the word, isn't it? It's reasonable. Like so. Yeah. It's measured, reasonable approach. Like, and it's based on the best available evidence, and utilising that in an informed manner, not just saying we've taken this evidence and we've made a black and white guideline. You do this. It's not algorithmic, logarithmic. Sorry, it's like human beings are not computers.
Medicine is very dangerous.
Yeah, for sure.
You can go down the wrong part of that algorithm very easily.
Yeah, for sure. Yeah, exactly. Brilliant. Cool.
All right. Well, thank you, Felix.
No, thank you very much, Andrew, for having me, and look forward to doing the next one with you.
Yeah, we will do part 2.
Yeah, for sure. Yeah, and then we'll do some other stuff in the series as well that we've talked about.
Okay.
Brilliant.
All right, guys. Well, thanks. I hope you enjoyed this talk with Felix. We will have this posted pretty shortly, and hopefully we will do some follow-ups.
Brilliant. Thank you very much.
All right, take care, guys.
Take care. Bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.